So a subtype of lymphoma called mantle cell lymphoma has been a chronic, treatable lymphoma. Treatments work, but they typically lead to remissions for a short period of time, and then eventually patients have to deal with a relapse. For the longest period of time, mantle cell lymphoma has been an unmet need with regards to the fact that a lot of patients continue to struggle with relapses over and over again. About a decade ago, all we had was chemotherapy. However, over the last 1 decade, there have been substantial improvements for patients with mantle cell lymphoma. One of these improvements come in the form of a tablet called a BTK inhibitor. These tablets work in about 60 to 70% of patients. However, majority of patients would enjoy remission or would enjoy just the efficacy of this tablet for maybe up to a maximum of 3 to 4 years. So with that in mind, we needed to figure out what to do for patients who relapse after a BTK inhibitor or a Bruton tyrosine kinase inhibitor failed. And with that in mind, several studies were launched. One of the studies was the Transcend NHL 001 MCL study. It's a mouthful, but basically this study investigated lisocabtagene maraleucel, which is a CD19 CAR T cell therapy. Let's call it lisocel. So lisocel was investigated in patients with relapsed mantle cell lymphoma, in patients who have failed 2 or more lines of treatment. So they must have had chemotherapy, and then they must have failed 1 BTK inhibitor, and then they were eligible. About 104 patients were screened for this study. 88 patients received the product, and at a median follow-up of only about 1.5 years to 2 years, they saw that a majority of patients, nearly 73% of patients, enjoyed a complete remission. And that has been unheard of in the past with the tablets that we used to have. Usually, if anybody progressed after the tablets failed, then patients typically had a pretty dismal overall outcome. So lisocel provided this new, fresh breath of air for patients with relapsed mantle cell lymphoma if they have had failed chemotherapy and then a BTK inhibitor. Based on the results, the medical authorities approved lisocel in patients with mantle cell lymphoma if they have had received 2 or more lines of treatment. The data that I'm presenting at the European Hematology Congress is with regards to understanding were responses compromised in patients who have received more lines of treatment than not, and were responses compromised if the response to a BTK inhibitor was not there, or if patients had just relapsed, meaning patients responded to relapse versus not responded at all, meaning the refractory set. So with that, this is called a post hoc analysis of a subgroup within this trial. The net is that if patients, we divided the prior lines of treatment into 3 groups, patients who had received 2 lines of treatment, 3 to 4 lines of treatment, and 5 to 11 lines of treatment. And as I mentioned, the complete remission rates in patients with the entire cohort was 73%. But what we did note that in patients who had received 5 or more lines of treatment, their complete response rates were slightly lower at 65%. The same was true of their ability to stay in a remission. Their ability to stay in a remission was slightly short than patients who had received less than 5 lines of treatment. With regards to toxicity, this construct was extremely well tolerated. There were no new side effects, cytokine release syndrome, neurological toxicities, which are unique CAR T related toxicities, were all manageable. Majority were all low-grade toxicities and completely reversible. With regards to the second cohort that we analyzed between the refractory and the relapsed BTK inhibitor population, we noted that the responses, meaning complete response rates, were slightly lower if patients hadn't responded to BTK inhibitor at all versus if they had responded to later relapse. The same was true of their survival as well in terms of their ability to stay in remission, so which is progression-free survival, or the duration of remission was shorter if patients had been refractory to a BTK inhibitor. It's also important to note that patients who had 5 or more lines of treatment, they were more enriched for patients who were also refractory to a prior BTK inhibitor. So that goes on to show that this construct works. It works in relapsed mantle cell lymphoma, but potentially we need to start giving it, we need to start administering it, we need patients to receive it especially if they have had less than 5 lines of treatment. So it's a call to all physicians out there now that this construct is approved, that I think using it in the 3rd and the 4th line setting is probably going to be of much more value than to use it in the 5th and beyond setting, so that our patients can enjoy the remission and the benefits because the toxicity of this regimen is negligible. So with that, I hope to have presented some of the latest data in mantle cell lymphoma and diffuse large B-cell lymphoma. I hope you've had a good time listening to this.